This is Dr. Luke Evnan, Chairman of the Scleroderma Research Foundation. This is the 11th webinar in our series, and if you've missed any, please feel free to view them online at our website, sclerodermaresearch.org. The SRF is America's leading nonprofit investor in scleroderma research, and it's only because of you. Please consider making a donation after our time together today. And also, I'd like to thank Gilead Sciences, MedImmune, and Novartis, all for their commitment both to scleroderma patients and for making this webinar series possible. It is my pleasure to introduce Dr. Lorinda Chung, Assistant Professor of Medicine and Dermatology at Stanford University School of Medicine. Lori is involved in clinical, translational, and epidemiological research on scleroderma and related connective tissue diseases. She's the principal investigator for multiple clinical trials, and she's also the secretary of the Scleroderma Clinical Trials Consortium, as well as the founding member of the Northern California Scleroderma Research Consortium. It's my pleasure to introduce Dr. Chung today and her presentation on skin manifestations in scleroderma. Lori?
Thanks so much, Luke, and thank you all for bearing with us and staying online. Hopefully we can get through the talk without any more difficulties. So I'm going to talk about skin manifestations of scleroderma today and basically give you an overview of all the various skin manifestations that patients can experience. So first, touching upon skin tightening, which is the most prominent feature that patients can experience, digital ulcers, which about half of patients will suffer from, and then some less common skin manifestations, including paronychia, calcinosis, telangiectasias, problems with pigmentation, and lipodermatosclerosis, which some of you may never have heard about. So first I want to talk about skin tightening. And scleroderma literally means hardening of the skin. There are various forms of scleroderma, and it's important to recognize that not everyone who has scleroderma necessarily has the internal organ manifestations. Those with localized scleroderma usually get just a patch of hardening of the skin, which can be called morphia, or they can get a linear form of fibrosis or scar of the skin, as shown in this patient here, and that's called a form of linear scleroderma. Localized scleroderma only involves the skin, as opposed to systemic sclerosis, where there is autoantibody production and frequently internal organ involvement. So there are various subtypes of systemic sclerosis, and probably the most common one that you've heard about are the diffuse and limited forms, and I'll talk a little bit more about those. But I do briefly want to mention that there's a form of systemic sclerosis where there's internal organ involvement, such as pulmonary fibrosis, pulmonary hypertension, or gastrointestinal dysmotility, and yet there is no skin tightening that's visible on physical exam. These patients are called systemic sclerosis sine scleroderma and still have the autoantibody production and immune function dysfunction. However, they don't manifest any tightening of the skin. And then there's a group of patients who have overlap syndrome or mixed connective tissue disease. And these patients will have overlap features with other connective tissue diseases such as systemic lupus, rheumatoid arthritis, or inflammatory myositis. So this shows a diagram of the two major forms of systemic sclerosis. So the diffuse and limited systemic sclerosis forms are differentiated by the extent of skin tightening. Yes, there's a question. You can go ahead and type it on the chat. I can't hear your question. I'm gonna keep going, but feel free to type in your question if you have one. So the extent of skin tightening is how we define diffuse versus limited. And as you can see in this diagram, those with diffuse skin involvement have tightening that can involve the entire body, so involving the face, the trunk, the hands, the feet, as well as the more proximal parts of the arms and legs, such as the upper arms and the thighs, as opposed to limited patients who can get skin tightening just involving their face and beyond their elbows and knees. Oftentimes, these patients will only have involvement of their fingers and toes as well as their face. So this is just describing, again, the differences between diffuse and limited systemic sclerosis. And these two groups of patients follow different courses of disease. Usually patients with diffuse disease will have rapid skin tightening around the same time that they develop Raynaud's phenomenon, maybe within months to a couple of years. And it's during that early phase of skin tightening that they have a lot of issues with internal organ disease. There's also associations with an antibody called the anti-SCL70 or anti-topoisomerase antibody in the diffuse group. This compares to the limited group where, again, the skin tightening is less widespread. And these patients usually will have Raynaud's phenomenon for years before they develop any skin tightening or any internal organ involvement. There's a group of patients with limited systemic sclerosis who have an anti-centromere antibody and are at higher risk for developing pulmonary hypertension. So you may have heard the term CREST, standing for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. And this is a term that we kind of try and steer away from in more recent years. It used to be considered synonymous or similar to patients with limited skin involvement. But now we recognize that patients with diffuse skin involvement can have all of these findings as well. So we're trying to steer away from using the term CREST any longer. So in terms of evaluating patients with skin thickening, you'll note that whenever you go to see a scleroderma specialist, they'll be pinching your skin in various areas of your body. And this is an instrument called the Modified Rodnan Skin Score, which is a measure of skin thickening that is used in clinical trials for systemic sclerosis. And it's pretty subjective, but it has been shown to basically correlate with how much internal organ involvement patients with diffuse skin involvement will experience, as well as those with really high measures on the Modified Rodnan Skin Score tend to have worse survival. So what do we do when we see a patient with systemic sclerosis? We evaluate 17 different body areas, which are listed there: the face, chest, abdomen, fingers, hands, forearms, upper arms, feet, lower legs, and thighs. And we give each body area a score for how tight we think the skin is. So 0 is totally normal, soft skin. 1 is mild thickening. 2 is moderate, where you're unable to move the skin. And then 3 is hidebound, where you can't even pinch the skin. And we sum up all the scores for the 17 different body areas, and you get a total score between 0 and 51 being very, very severe skin tightening. So as I mentioned, the patients with diffuse and limited skin involvement tend to follow different natural history of disease. And as you can see, the patients with diffuse skin involvement tend to have rapid skin tightening early. This is kind of the rate of skin thickness that is measured on the y-axis. And at the same time that there is a lot of skin tightening, you get problems with development of joint contractures, GI, lung, heart, and kidney involvement. That is the time you're at risk for developing these problems. Then it sort of slows down, and patients actually will get some softening of their skin later in the course of their disease. Limited patients tend to have a much slower progression of their skin thickness. And again, early on it's probably a more rapid rate, but then it sort of slows down and stabilizes. However, it's later in disease where there's the higher risk for developing problems with internal organ involvement, such as pulmonary hypertension and gastrointestinal involvement with malabsorption. So looking in particular at patients with the anti-SCL70 antibody, which is an antibody typically associated with diffuse skin involvement. But there is a group of patients who have limited skin involvement with this antibody as well. And this antibody in particular is associated with an increased risk for developing interstitial lung disease or pulmonary fibrosis. And when we look at this group of patients who have this antibody, they can actually be divided into different groups based on the rate of their skin thickness progression. So those who have a very rapid rate of skin thickness progression is depicted here, and then intermediate and slow. And these patients, they are different rates of skin thickness progression, but they all have diffuse skin involvement or widespread skin involvement. Then there are two other groups, those who start with limited skin involvement and slowly over time progress to diffuse skin involvement. And finally, there's a group that has limited skin involvement that really doesn't progress. They have maybe mild skin tightening in the first couple of years, but then they stabilize and they remain in the limited subset of patients. So why is this skin thickness progression rate important? So looking at survival rates, it's been shown that patients with rapid skin tightening, rapid or intermediate even, have the poorest survival. So this shows the survival rate here on the y-axis. And you can see that the survival rate at 10 years is 32% in those who have intermediate progression of their skin thickness and 36% if they have rapid progression. And this compares to slow progression of skin thickness of 70% survival, and even better if the patient started out with limited skin involvement and remained limited, or started out even with limited skin involvement and became diffuse, but did it in a slow fashion. These patients have the best survival. So really looking at the rate of skin thickness progression can help you in determining what the prognosis is or how you're going to do overall with survival and developing internal organ problems. So that was just a brief overview of skin tightening, and I didn't at all get into the pathogenesis or what causes the skin tightening. And there's lots of active research going on in this area. We know that scar tissue is laid down, and there are molecules such as connective tissue growth factor and transforming growth factor beta that are involved in leading to the scar tissue that develops in the skin. We also know that autoantibodies are involved, and there are clinical trials that are using agents that target cells in the body that produce these antibodies, such as B cells. And then there are other growth factors that have been found to be important in leading to scar tissue development in the skin. And some of these drugs are approved for treating various cancers like imatinib and dasatinib and have been used in patients with systemic sclerosis with some benefit in a subgroup of patients. The immune system is definitely revved up in scleroderma, and T cells are a form of cells that release these molecules in the blood that can lead to skin tightening and scarring in multiple organ systems. So there are a bunch of drugs that are currently being tested to target the T cells in treatment of skin disease in scleroderma. So the asterisks denote that there are current clinical trials that are evaluating some of these agents for the treatment of skin tightening. So now I'm going to move on and talk about digital ulcers. As I mentioned, digital ulcers can occur in about 50% of patients, and they can either have limited or diffuse skin involvement. And usually these ulcers are very painful and heal slowly, and they can occur at the tips of the digits or overlying their joints, sometimes involving the hands. So it causes problems with hand mobility. You can have scarring and loss of your fingertips over time. And obviously there are major problems such as infection that can eventually infect the bone and cause osteomyelitis. And then there's problems that you can get where the tissue dies actually at the fingertip, leading to gangrene and the need for amputation. So here's just a picture of a digital ulcer of one of our patients. So it can occur either at the causes that contribute to the development of digital ulcers in patients with scleroderma. As I mentioned earlier, most patients with scleroderma suffer from Raynaud's phenomenon, which is a spasming of the blood vessels that leads to color changes of the fingers due to lack of blood flow to the fingers. So often a blue, purplish, or white color when there's lack of blood flow. And when this happens over and over again, this leads to loss of blood flow to the fingertips. So if you don't mind, I'm going to hold the questions for a little bit later unless they're directly related to what I'm talking about right now. So I'm going to continue, but I will answer your questions later on at the end of the talk if that's okay. So other causes of ulcers in patients with scleroderma, probably the main reason is that there's an underlying vasculopathy, or there's a problem with the blood vessels in patients with scleroderma, and I'll show you exactly what I'm talking about in a minute. Patients also get problems with little blood clots that occur along the blood vessels, leading to a problem with blood flow. You can also get ulcerations at sites of calcinosis, or calcium under the skin. And then those patients who have really tight skin that develop contractures, like over their fingers, they can develop ulcers over their joints, partly related to repeated trauma and banging your joints by accident, and partly related to the fact that there's tight skin overlying the joints, and thus it's very difficult for healing to occur. So this is a photomicrograph of a digital artery from a patient with systemic sclerosis. And this just shows what the vasculopathy, or the blood vessel problem, is that I was referring to. So all this in blue represents scar tissue. And you can see that scar tissue is pretty much encasing the entire digital artery. And in addition, this area here should be one cell layer thick, but instead it's replaced by this large amount of scar tissue. And thus you can see this opening of the blood vessel is diminished. It really should be about 10 times the size of what's there now. So obviously this leads to decreased blood flow to the fingers. Some of the risk factors associated with developing digital ulcers include being a male, having the problem of pulmonary arterial hypertension, having severe involvement of the esophagus, diffuse skin involvement has been associated with more digital ulcers, having Raynaud's for a long, long time, so young age of onset of Raynaud's, and having inflammation in the bloodstream as noted by an elevated sedimentation rate. So this is what we clinically can see if ulcers progress to gangrene. You can see this patient has multiple areas of gangrene and had a prior amputation from an event years earlier. And we do what's called an angiogram, where you shoot dye into the blood vessels to see how good the blood flow is. And as you can see, the blood flow is sharply discontinued at the fingers. And so all of these fingers here are getting poor blood flow. So this diagram kind of goes through the cause or the pathway that occurs before there's injury and lack of blood flow and oxygen to the fingers. So initially, there's some environmental trigger, we're not sure exactly what, but it causes the immune system to be activated. Autoantibodies develop, those T cells or immune cells get activated, and this leads to injury to the blood vessels. Capillaries are destroyed and platelets are activated. And then there's also fibrin deposit and clot or thrombosis that occurs along the blood vessels. Then there are problems with various markers in the blood that lead to vasoconstriction or closing off of the blood vessels. This includes increased endothelin-1 and decreased nitric oxide and prostaglandin. So when you get problems with these hormones in the blood, it basically leads to closing off of the blood vessels or luminal narrowing and leads to decreased blood flow to the tissues. So this just gives you an overview of sort of how we treat and prevent digital ulcers in patients with systemic sclerosis. Whenever we have a patient who comes in for the first time to our clinic, we always ask them if they've ever had digital ulcers in the past and whether or not they have them currently on exam. We certainly look for that. So if they've had them in the past but don't currently have them, we treat them a little bit different than if they currently have digital ulcers on exam. So if they've never had digital ulcers in the past or currently, then we treat their Raynaud's as aggressively as possible. And yes, RP stands for Raynaud's phenomenon. And so essentially 90% of patients will have significant Raynaud's phenomenon. And we treat them with various drugs, including calcium channel blockers, which are blood pressure medications, ACE inhibitors, another form of blood pressure medication. We even treat them with medications called selective serotonin reuptake inhibitors, otherwise used for depression or antidepressants, such as Prozac. We also tell patients to avoid things that trigger their Raynaud's phenomenon, such as cold, stress, and trauma. We counsel all of our patients that if they smoke, they should stop smoking, and if they're able to tolerate a baby aspirin, we put most of our patients on a baby aspirin to help with the blood flow. So if patients have had digital ulcers in the past but don't currently have any, we may treat them a little bit more aggressively with higher doses of medications that open up the blood vessels or vasodilators, such as calcium channel blockers. Statins, which are drugs that we use to lower cholesterol, have also been shown to be helpful in the treatment of Raynaud's and digital ulcers in patients with scleroderma, though larger trials are currently being planned. And then there are other drugs that we use to treat pulmonary hypertension. They're approved for the treatment of pulmonary hypertension that we sometimes borrow to try and use in patients with Raynaud's phenomenon and digital ulcers. And these include drugs like Viagra, otherwise known as phosphodiesterase 5 inhibitors, a very long word, and bosentan or ambrisentan, endothelin receptor blockers. So if a patient comes in with one or maybe two digital ulcers on exam, then we will treat the ulcers possibly with hydrocolloid occlusion, which I'll show you a picture of in a minute. We treat any infections that they might have, and we also give them the vasodilators or medications that open up the blood vessels. Silostazol is a medicine that is often used to treat patients with peripheral vascular disease or thickening of the arteries in some of the larger blood vessels. And we've noted that this can help heal up ulcers in patients with scleroderma as well. If patients have multiple or very severe digital ulcers, then we may even admit them to the hospital for treatment with very strong vasodilators that open up the blood vessels called prostacyclins. These drugs, like the phosphodiesterase inhibitors and endothelin receptor blockers, are approved for the treatment of pulmonary arterial hypertension, but not approved for the treatment of digital ulcers, though we have seen some benefit using these drugs when there are severe ulcers or gangrene occurring. Another thing I wanted to mention that we have had a lot of success with at Stanford is digital sympathectomies. We have a hand surgeon at Stanford who has performed sympathectomies on probably a third of our patients at this point and really has had some major benefit. Basically, he brings them to the operating room and strips off the scar tissue around the digital arteries to open up the digital blood vessels and help with blood flow. let's see, does exercise and or fish oil help? There has not been any studies looking directly at fish oil to see if this is beneficial to digital ulcers in scleroderma, but I certainly don't think it would harm anything. And there is obviously research looking at using fish oil, vitamin E, et cetera, for looking at coronary artery disease. Okay, so I'm going to keep moving forward. I know there are a lot of questions coming through. So this is, I just wanted to show you what duoderm looks like, or that hydrocolloid occlusion that I was talking about that we can use to help promote the healing of digital ulcers in scleroderma. It serves as a barrier, so it prevents infection, and it kind of allows the closing of the wounds to occur more quickly. This is used also for diabetic ulcers, and sometimes can be difficult if you have, a fingertip ulcer. Sometimes it's difficult for the hydrocolloid to stay on the fingertip. So it's not used in all patients, but certainly in those who have larger ulcers or ulcers overlying the joints, you can try this hydrocolloid or duoderm. So how do you use duoderm? It's pretty easy. Basically, you clean the area with water and soap. You apply some polysporin or antibiotic ointment to the wound site, and then you cut the duoderm about half to an inch beyond the wound's margin, and you apply the duoderm over the wound. The dressing should be changed about every third day or sooner if there's some oozing of fluid from the ulcer site. So I am going to move on to some of the less common skin manifestations that scleroderma patients can get. Paronychia is a skin infection that occurs around the nails and presents as painful, red, and swollen right around the nail. And it's usually due to an opening in the skin barrier right around the nail. So these are infections related to bacteria, yeast, or fungus. And it hasn't been well studied in patients with scleroderma, but we certainly see it in our clinic quite a bit. So in terms of the treatment, we will use antibiotics if it's an acute form or happens all of a sudden, really red, hot, and swollen, and possibly actually draining the fluid out of the fluid pocket. In more chronic cases where it seems like it's been going on for weeks and weeks, it's more likely to be a fungal infection, and we use fungal medication as well as topical corticosteroids. In order to prevent paronychia from occurring, basically you want to avoid trauma to the nails or your fingertips. We really tell patients that if they're going to go get a manicure or pedicure at a nail salon, to bring your own tools and make sure that you sterilize them yourself. Oftentimes patients with scleroderma will have very long cuticles that are ragged, and it's so tempting to just pick away at those cuticles or to trim them. But you really want to be careful when you do this, and if at all possible, try and avoid doing so and just let the cuticles grow on their own and really don't cause any trauma to your nail. The other way you can prevent infection of the nail bed is using Aquaphor or Vaseline around the cuticles. It serves as a barrier for bugs to get in. Calcinosis. Calcinosis can be a real problem in patients with scleroderma. It's essentially calcium deposits under the skin and can occur in patients with either limited or diffuse skin involvement, despite the fact that patients with limited skin involvement have been the ones classically to be described with calcinosis. Common locations, mostly the hands, but it can occur on the arms, the elbows, the knees, can even affect the trunk. Usually they're little nodules of calcium, but occasionally you can get more plate-like or plaque-like calcium deposits under the skin. And that's more common in patients who have dermatomyositis. So how do we evaluate for calcinosis? Sometimes you can see it and feel it on physical exam, as shown in the previous picture. But to really confirm that it's present, we do x-rays. And okay, I'll try to speed things up. CT scans can also be used, and ultrasounds are more experimental. So unfortunately, the treatments for calcinosis are not very effective. Probably the most success that we get is from surgical removal. Sometimes if there's a lot of inflammation around the calcium, then minocycline can be helpful. So telangiectasias, these are small dilated blood vessels near the surface of the skin. And lots of patients can get telangiectasias just related to sun exposure, and it usually looks more stellate in appearance like this if it's related to sun exposure. Whereas in scleroderma, you get these particular matted or square-like telangiectasias. And these are really more specific for systemic sclerosis or scleroderma. Usually happens later on in disease, and common places, hands, fingers, the mouth, face, chest, and the arms. You can also occasionally get them over the joints and around the nails. So here's just some pictures of showing the telangiectasias around the nails, and you can get telangiectasias over the joints as well from scarring. Here are multiple matted telangiectasias on the face. So why are telangiectasias important? There are some associations with telangiectasias. Usually patients are older. African Americans are actually less likely to develop them. Former or current smoking can increase your chances of getting these. And the longer you have the disease, the more likely you are to develop multiple telangiectasias. There's also an association with an increased risk for pulmonary arterial hypertension. So this is a study performed by the Hopkins group showing that there was a strong correlation between the number of telangiectasias and the duration of their scleroderma. And then looking at those with pulmonary hypertension versus those without pulmonary hypertension, there was a more than 12-fold increased risk of pulmonary hypertension for every time you had an increase of 10 points of your telangiectasia score. So obviously the more telangiectasias, the higher the risk for developing pulmonary hypertension. So unfortunately, treatment of telangiectasias is very difficult and not covered by insurance. The good thing is it's mostly cosmetic. It's not going to harm you internally. But there are some experimental protocols looking at various laser dyes in the treatment of telangiectasias. And here's a prior study from the 1990s showing a particular laser therapy that was somewhat successful in the treatment of telangiectasias. And there was a more recent study looking at intense pulse light and was found to be effective in about 3/4 of patients who were treated with this. And here's just an example of what the telangiectasias look like before and after treatment with this intense pulse light. So in terms of hypo and hyperpigmentation, having either white areas or really dark areas of the skin, unfortunately, there's not a known cause of the pigment change except for the fact that there was prior inflammation there that can definitely lead to changes in the pigment in the skin. The salt and pepper appearance is probably the most common that you can see, and it's called salt and pepper because there's white appearance as well as darker appearance, hypo and hyperpigmentation in this. And unfortunately, this is a damage, a marker of damage, and no really good treatments are available for the treatment of the pigment changes. So lastly, I'm going to talk about Lipodermatosclerosis, which is fat inflammation that can be seen in those with chronic leg swelling as well as in autoimmune diseases. And we definitely have a group of patients with scleroderma who suffer from lipodermatosclerosis. So this is what it looks like. You get chronic inflammation and scar tissue of the skin and subcutaneous tissues of the lower legs, and it causes this bound down appearance, which is hard to differentiate or hard to tell whether it's related to their systemic sclerosis or if it's something else. And it can just be a plaque of skin tightening, or it can involve the entire lower leg. So there are classic appearances once it really bounds down the skin, and it leads to this inverted champagne bottle appearance where you can see it kind of looks like a champagne bottle here. So as I mentioned, we don't know how common lipodermatosclerosis is in patients with systemic sclerosis. It may be associated with antiphospholipid antibodies, which are antibodies that increase the risk for blood clots in patients with autoimmune diseases, certainly related to having a lot of leg swelling. So those whose veins are kind of floppy or have venous insufficiency definitely get a lot of leg edema and are at higher risk for developing lipodermatosclerosis. So initially these lesions are painful and red, and then eventually become hyperpigmented or darker and bound down in terms of the skin. And in about 13% of them, they can even lead to ulceration of the skin. In terms of treatments for lipodermatosclerosis, compression stockings are the primary treatment, and that's to help with the leg swelling. But there are other drugs that can be used to try and bring down the inflammation and help break up the scar tissue. There's a modified testosterone derivative called danazol that can be helpful in breaking up the scar tissue. I'll be done in just 2 minutes. So intralesional steroids can be used where we actually inject steroids into the skin. And then a drug called pentoxifylline or Trentol can decrease the sludging of blood and help with the treatment of lipodermatosclerosis. For non-healing ulcers, you might need to actually have surgery done to take those out. And then topically, you can use capsaicin to help with the pain and inflammation. So just in summary, scleroderma is characterized by skin tightening, but the extent and rate of skin tightening differs among patients. Digital ulcers and paronychia are related to the abnormal blood vessels in patients with scleroderma and due to poor wound healing. Calcinosis, telangiectasias, pigment problems, these are all signs of skin damage, and we really don't understand them and unfortunately don't have great treatments for them in scleroderma, but there's currently a lot of ongoing research looking into these areas. So I just want to finish with thanking all of my colleagues at Stanford who make up the Stanford Scleroderma Center. First of all, my partner in the multidisciplinary clinic, David Fiorentino, my pulmonary colleagues, Glenn Rosen, Rohan Zamanian, and Mark Nichols, translational colleagues in the lab, Howard Chang in dermatology, Bill Robinson and PJ Utz in immunology. I mentioned our vascular surgeon, James Chang, who does fantastic work, surgery, doing digital sympathectomies on our patients, and Francois Haddad, who helps us with the echo labs in cardiology. And of course, I want to thank the Scleroderma Research Foundation for their continued support of our center, and thank you for inviting me to present at this webinar, and thank you all for attending. And I'd be happy to take the questions at this point.
Great, Lori, that was super. Thank you so much. I've tried to group a couple of the questions, so let me just try and roll up a couple questions into one here, which is, do you want to just talk a little bit about sort of your thought process as, on a generic basis as you think about immunosuppressives and how that might impact the management of, let's say, skin thickening? I guess the question would be sort of what drugs, what's the sequence of drugs that you might typically run through, and what has been your experience in terms of the likelihood of response of the skin thickening, and then talk maybe a little bit about the time course to response.
Yeah, those are great questions. So the first thing I would say, the first point I would make is that the earlier you treat, the more likely you're going to get some benefit. And it's really hard to say. As I showed you, in the natural history, patients will improve on their own typically over time. The degree of improvement varies per patient, and the timing of improvement varies per patient. So what we really try to do is get the patient started on treatment as early as possible within the first couple of years of their onset of the skin tightening. And I would say it depends, again, patient to patient, what we would choose. But typically, we will start with either methotrexate or Cellcept, depending on whether or not they also have interstitial lung disease. If they do have interstitial lung disease, we'll use Cellcept over methotrexate. And we definitely have had good success with both of those drugs in both slowing down the progression of skin tightening and even reversing some of the skin tightening. It's hard to say whether those patients were going to get better on their own or not, but we do feel that those patients that we don't treat for one reason or another, they seem to progress more rapidly. So those would probably be our first-line therapies. Cyclophosphamide is something we might use in patients who are really rapidly progressing, or if they have interstitial lung disease as well. And then we also use probably less frequently tried medications such as IVIG and rituximab we have used in patients. And then after those medications, really we're looking at clinical trials, and we're constantly trying to enroll patients in clinical trials for agents that are likely to counteract the scar tissue in the skin. So we recently completed enrollment for a multi-center study looking at a new drug that fights a molecule in the bloodstream called interleukin-6. Tocilizumab is the name of the drug, and it's approved for rheumatoid arthritis. And so hopefully we'll see in the next year or so whether patients experience improvement from that drug.
And maybe just along the same lines, Lori, there's a number of oral agents sort of coming through the pipeline. I don't know if you've had personal experience with some of those. They're more in the vasodilator class, broadly cast. Do you want to speculate at all on sort of the efficacy that you think those might offer as compared to the drugs that are currently available?
So are you referring to the endothelin receptor antagonists, or which class of drugs are you referring to? I guess I'm talking predominantly about sort of the Riosogate. This is the cyclic GMP inhibitor from Bayer, and Actelion selexipag, which is, again, a prostaglandin receptor modifier, both orally available, both in late-stage clinical trials now. I don't know if you've... Yeah, they're in clinical trials for pulmonary hypertension, but I have not personally used them for the treatment of skin tightening in scleroderma patients. And I know Roham Zamanian, who's my pulmonary hypertension colleague, was involved in clinical trials. I'm not sure if with both of the agents, but they certainly haven't been measuring the Rodnan skin score or the skin tightening in those clinical trials, so I'm not sure what the data is there. Right.
And Lori, I know that historically calcium channel blockers have been prescribed a lot for vasospasm in particular, I think. And I think my understanding is some patients have problems with reflux as a component of that. Do you want to just talk a little bit about how you guys use calcium channel blockers?
Yeah. So, for Raynaud's phenomenon, calcium channel blockers can be really effective. Probably at least in a third to a half of patients, we see some benefit from calcium channel blockers. They definitely can be problematic and not tolerated due to not only the reflux issues, but headaches, leg swelling, lowering of the blood pressure. A lot of our patients start out with quite low blood pressure, and so can't tolerate a dose of a calcium channel blocker that would actually help their Raynaud's symptoms. So certainly we'll try a calcium channel blocker initially. If it's tolerated, we'll titrate it up to a dose that can hopefully control their symptoms without dropping their blood pressure too low. But if we have problems with calcium channel blockers, we typically, if their Raynaud's is really severe, we'll typically go to a phosphodiesterase inhibitor like Viagra or sildenafil. We do have to usually write a letter to the insurance company to get them to approve the medication. But really we found a lot of success with these phosphodiesterase inhibitors for treatment of Raynaud's. Other things like the antidepressants that I talked about, the SSRIs, we see some benefit with that and definitely use those to treat patients who have low blood pressures and wouldn't be able to tolerate these other vasodilators or medications that open up the blood vessels. And like I mentioned, we do use baby aspirin. We sometimes use other blood pressure medications like ACE inhibitors. Though I must say the success with those compared to the sildenafil or Viagra drugs are definitely less in our experience.
And we're starting to run out of time, Laura. Do you have just a couple minutes to sort of we can extend, because I think there's still a couple more questions.
Sure.
Okay, so we'll go over just a little bit for those folks who want to try and hang on. Obviously, digital ulcers can be extremely painful. Do you want to talk a little bit about how you manage some of the pain and what kind of medications you tend to favor for that?
Yeah, so we usually try to steer away from narcotics if necessary, and just treat with over-the-counter pain medications such as Tylenol. And then if we're looking at prescription medications, we use a lot of tramadol, which can be helpful. But then beyond that, you are starting to go towards more narcotic forms like Vicodin and higher level narcotics. We definitely feel it's necessary to treat the pain associated with digital ulcers and usually work with either the primary care physician or the pain clinic in managing the narcotic medications. So, there is definitely a need to treat the pain, and so patients shouldn't fear that they're going to become addicted to these medications. It's to treat true pain related to their digital ulcers, and so narcotics are definitely indicated in that circumstance.
Let's see. There's been several different questions about calcinosis and what are the basically sort of manifestations, and then I guess what are some of the treatment options. I think you did review that in that one slide, but maybe it's just worth talking a little bit about again, because my impression is that calcinosis, the presentation has extremely variable characteristics, and maybe it's just worth reviewing for the audience here sort of the wide range of presentations so people can appreciate what they might have and what they might not have.
Sure, yeah. So you can see in this slide here, this is pretty significant calcinosis that's causing deformities in the fingers and the hands. Patients can get pretty widespread calcium, and on X-ray, you'll see lots of individual nodules that can come together and form a big glob. Other times, you can just get one little speck of calcium, and it won't be bothersome at all. May come to the surface and extrude a little bit of white chalky stuff and go away. So definitely there are patients who will have calcinosis, small lesions that will resolve completely on their own. But in terms of the more difficult calcium deposits that can grow and they really don't go away on their own, we do try to treat them. And I didn't go through the entire slide because I know we have lots of drugs that we've tried and unfortunately haven't been very effective, like warfarin. Probenecid is a gout medicine that a couple of patients have benefited from in terms of calcinosis, but we really haven't seen benefit in a lot of patients from probenecid. Colchicine, another gout medication that can somewhat help in bringing down the inflammation around calcium, but really doesn't dissolve it. Alendronate is used to treat osteoporosis, and there have been reports that it's been helpful. We really haven't experienced that. The calcium channel blockers, maybe some benefit in the treatment of calcinosis, and as I mentioned, minocycline is probably the one that we would try the most if there's evidence of redness or inflammation around the calcium. Okay, where calcinosis is likely to occur beyond the hands, it can occur over the joints. It can occur anywhere along the extremities. Even can occur on the trunk, though that's probably a little bit less common. The most common place is the hands, but over the joints and anywhere on the extremities can happen. So surgical removal, if the lesion is accessible to surgery, has really been where we've gotten the most benefit in terms of treatment of calcinosis, but it can recur.
Well, Lori, this has been fantastic, and I really appreciate your time today. We're going to have to wrap up now. I do want to thank all of our participants. It's been great to have such a broad audience, including some dialing in from the United Kingdom. Please, when you close the webinar window, you can help provide some valuable information and feedback for us by completing a very short survey. And please, remember, we depend on your support. I hope you'll visit us online at sclerodermaresearch.org or just call our offices at 1-800-441-CURE. That's 1-800-441-CURE. Thanks again for sharing some time today, and we look forward to bringing our 12th webinar to you in the months to come. That will be Dr. Laura Hummers of the Johns Hopkins Scleroderma Center, and the current date is Tuesday, September 17th. Bye-bye for now.